Hi, everyone, and welcome to our module on lung cancer. Let's talk about which cancers are most common. So, breast cancer is the most common cancer for women, and prostate is the most common for men. Lung is the second most common for both men and women, but it's the most deadly. And then the next most common is colorectal. Let's talk about the risk factors for lung cancer. So, far and away, the most important risk factor is cigarette smoking. And the reason cigarette smoke is bad is because it contains molecules called polycyclic aromatic hydrocarbons. And these are a number of different molecules that are all toxic to the lungs and can trigger lung cancer. Another important risk factor is radiation therapy. So, survivors of Hodgkin's lymphoma or breast cancer often have received a significant amount of radiation to the chest, and this can trigger lung cancers to develop much later in life. And then finally, there are a couple of environmental toxins that can lead to lung cancer. One is asbestos. This is used as insulation in ships and roofing and around pipes. And if you inhale asbestos, you can get asbestosis, which is a risk factor for lung cancer. And also radon. So radon is a naturally occurring substance that can get into homes through the ground. And most people, when they purchase a home, have it tested for radon levels, because if the levels are high, that can lead to lung cancer if you live in the house. Lung cancer is usually pretty advanced by the time symptoms develop. So most people are not detected when they have a very small tumor. They're often detected when it's large and unfortunately metastatic. The symptoms are usually related to the lungs, so they will have cough, maybe shortness of breath. Sometimes the tumor bleeds or it grows into a blood vessel, and this leads to hemoptysis. And when patients have these symptoms, this usually leads to chest imaging. I've unfortunately diagnosed lung cancer in a few people who've come to see me for a question of dyspnea related to a heart condition. And when we do a chest x-ray, we find the tumor and realize that lung cancer is the cause. What you see on chest x-ray in patients with lung cancer is a pulmonary nodule. It's also sometimes called a coin lesion. This is an example of one over here. Inside this black box, you see that there's this white area on the chest x-ray. It's subtle, but you can clearly see it's different from the right lung. There isn't anything like that present over here. And that's what a pulmonary nodule looks like on chest x-ray. The most important thing to do when you uncover a pulmonary nodule is compare with prior imaging. If you happen to have an x-ray from a few years ago, if the nodule was present back then, it means it's most likely benign because it's not changing in size. Nodules that are new or changing in size are more likely to be malignant, and then biopsy is what you need to do to make a definitive diagnosis. So what are some causes of benign pulmonary nodules? One of the most common causes are granulomas, and we'll talk about that in a minute, but these are usually people who previously had tuberculosis. Another common cause is a hamartoma. So hamartomas are lesions that are made up of normal tissue, but it's disorganized. So a lung hamartoma is going to have normal lung tissue and cartilage that's disorganized with scattered calcification, and these are benign. So the two reasons granulomas often form are prior fungal infections or prior mycobacterial infections. Histoplasmosis is one fungus that can leave granulomas behind, and this occurs in patients from the Midwest and the Mississippi and Ohio River valleys. And coccidioidomycosis is another fungal infection that occurs in the Southwest and California, all the areas down near Mexico. Both of these fungal infections can be very mild or even asymptomatic, so patients may not know they've had the bug, and then when they get a chest x-ray, you'll see an old healed granuloma. Another reason is prior mycobacterial infection, and this is usually tuberculosis. So primary lung cancers are divided up into the small cell cancers and the non-small cell cancers. And the small cell are the more rare type, but they're the much worse type. You don't want to have a small cell cancer. These are fast growing and they have early mets. Because they grow so quickly and metastasize so quickly, they're usually not amenable to surgical resection. These occur in smokers and they're treated with chemotherapy, and they overall have a very poor prognosis. Non-small cell cancers, on the other hand, are the most common type, and these can sometimes be resected. They have a better prognosis, and some of them occur in smokers and some of them occur in non-smokers. So let's talk about the small cell cancers first. These are composed of very poorly differentiated small cells, and they're very easy to recognize in a picture because all you see are lots of dark purple nuclei like what I've shown over here. This is a classic cancer to occur in a male smoker. And remember that they are neuroendocrine tumors, and the easy way to remember that is that these cancers have a lot of associated paraneoplastic syndromes, which we'll talk about in a minute, and that's because they have neuroendocrine activity in the cells. These like to occur centrally in the lung, so we'll talk about different tumors. Some occur centrally near the trachea, and some occur peripherally near the outside of the ribcage. These ones like to occur centrally. There are three paraneoplastic syndromes that occur in small cell cancer, and they all start with the letter A. So the first one is ACTH. So these tumors can secrete ACTH, which will stimulate cortisol production, and this will lead to the Cushing syndrome. So the cortisol production will lead to progressive obesity, and this will cause hyperglycemia. The second small cell cancer paraneoplastic syndrome is SIADH. You can remember the A for ADH. So these tumors can release antidiuretic hormone, and this will cause retention of water, and it will dilute the plasma, and the patient will develop a low sodium level. They'll have hyponatremia, and the symptom they get from that is confusion. The final paraneoplastic syndrome is antibodies. So these patients can get something called the Lambert-Eaton syndrome. This is where they have antibodies against presynaptic calcium channels in their neurons, and this blocks the release of acetylcholine. And the main symptom they're going to develop is neuromuscular weakness. This is somewhat similar to myasthenia gravis, and the patients will have difficulty moving their arms and legs or possibly even swallowing. And these are the three paraneoplastic syndromes that happen in small cell lung cancer. Now we're going to talk about the non-small cell cancer, and what's confusing about these cancers is that there are 5 different subtypes you need to know. So we'll talk about the squamous cells and the adenocarcinomas, and then we'll go into the large cells. And then 2 relatively uncommon subtypes are bronchiolo-alveolar carcinoma and carcinoid tumor. So let's talk about squamous cell carcinoma first. This is commonly going to occur as a hilar mass arising from the bronchus. So recall that the hilum is where the trachea branches into the 2 main stem bronchi and enters the right and left lungs. So squamous cell carcinoma is going to be a mass near the center of the chest, right near that bronchus. Some key pathology to know about is that these tumors produce keratin, so they have keratin pearls when you look at them under the microscope. Also under the microscope, you can see what are called intracellular bridges. These are little desmosomes between the different cancer cells. This is a common cancer in male smokers, and these tumors can produce parathyroid-related protein, which acts just like parathyroid hormone. This is going to lead to hypercalcemia. It's going to mimic the effects of parathyroid hormone. So the symptoms a patient is going to develop are stones, groans, and psychiatric overtones. I talk about this in the renal modules. Essentially, they're going to have bone and abdominal pain and have confusion from high calcium levels, and that's a result of the squamous cell carcinoma making parathyroid hormone-related peptide. Adenocarcinoma is a glandular tumor. That's why it's called adenocarcinoma, and you should know that this is the most common lung cancer in non-smokers, especially in women. So if you see a tumor that's in a non-smoker, especially if it's in the periphery of the lung, it's almost certainly an adenocarcinoma, especially on your boards. That's the classic presentation. Large cell carcinoma is called large cell because the cells are so poorly differentiated. All we can really say about them is that they're large. They don't have features that are definitely glandular or definitely squamous, and they aren't small cells. So it's sort of a cancer that doesn't fit into any other cancer categories. It's a smoker's cancer. It can be central or peripheral, and these ones carry a very poor prognosis. Bronchiolo-alveolar carcinoma is a subtype of adenocarcinoma. So remember, adeno is the type that non-smokers get out in the periphery, and it has many similar features to adenocarcinoma. It's also peripheral and also occurs in non-smoker. There are 2 types. There's a mucinous type, which comes from goblet cells, and there's a non-mucinous type, which comes from Clara cells or type 2 pneumocytes. And a key thing to know about this cancer is it looks like a pneumonia on chest x-ray. So these patients will have a whiteout in one lobe of their pneumonia. It looks like lobar consolidation. And these have an excellent prognosis. So surgery, radiotherapy, and sometimes adjuvant chemo often cures the cancer. And then the last tumor type I'll mention of the non-small cell tumors is the carcinoid tumor. These are relatively rare. They're neuroendocrine tumors. They have well-differentiated cells. They stain positive for chromogranin, and these occur in non-smokers. And you should know that even though they have the word carcinoid in the name, they rarely cause the carcinoid syndrome. So carcinoid syndrome is when a tumor secretes serotonin and it leads to flushing and diarrhea. And this more commonly happens with gut tumors that metastasize to the liver. These carcinoid tumors in the lungs very rarely cause this syndrome. Let's talk about some of the complications of having a lung tumor. One of the first things you can get is a pleural effusion. The lung cancer can cause an effusion. When this happens, you can tap the fluid and send it to the lab for cytology. And often you can identify the malignant cells in the pleural fluid, and this can help with diagnosis. Lung tumors can compress the phrenic nerve. When this happens, you get paralysis of the diaphragm on one side of the body. This can lead to dyspnea. On a chest x-ray, you can see elevation of the hemidiaphragm on the affected side. You also can sometimes do something called the sniff test. So this is when you put the patient under the fluoroscope and you look at their diaphragm. When they sniff, the diaphragm should go down towards the abdomen on both sides. If the patient has phrenic nerve damage on one side, say on this side right here, what will happen is the other side will go down and it'll push the diaphragm up on this side. So you'll see paradoxical movement, meaning the affected side goes up instead of down. And that's the sniff test, and it's a way to diagnose phrenic nerve problems. You also can sometimes get compression of the recurrent laryngeal nerve, which runs near the lungs, and if this happens, the patient can develop hoarseness. Another rare but important syndrome to know about from lung tumors is called the superior vena cava syndrome. This is where you have obstruction to blood flow through the SVC. This can happen from a tumor, so lung masses like non-small cell and small cell cancer can do it. It can also be done by other masses in the chest like lymphoma. And then another cause besides masses is thrombosis. So patients who have an indwelling catheter or a pacemaker can have these structures form as a nidus for a clot. And they can get a clot in their SVC, and this can obstruct the SVC the same way a tumor would. When you get obstruction of the SVC, the face will begin to swell, and the patient will say their head feels full. That's because the blood can't drain from the head. In addition, you can get swelling of the arm because the blood can't drain from the arm. And then finally, you can get increased intracerebral pressure because the blood can't drain into the SVC. This can cause headaches, confusion, and coma, and rarely it could cause a cranial artery rupture if it went untreated. Usually this is diagnosed by either a chest X-ray or a chest CT, and you can see a dilated SVC. Also with a chest CT, you can sometimes see the thrombus in the SVC. And there are various different treatment options. So if it's from a blood clot, anticoagulation is given. If it's from lymphoma, steroids are commonly given because they will shrink the tumor and relieve the obstruction. Sometimes urgent or emergent chemo or radiation is done, and there are endovascular stents that can be inserted to expand the SVC and allow the blood to drain. Pancoast tumor is a carcinoma at the apex of the lung. This is a picture of one in this X-ray over here on the right. Notice up here there's this white thing up at the apex of the right lung. That's the Pancoast tumor. Because of the location at the top of the lung, these can involve the superior sulcus, and this is a groove that's formed by the subclavian vessels. The result is that you can obstruct the venous drainage from the arm on the affected side and get arm edema. What makes this different from SVC syndrome is you won't see facial edema, just arm edema. In addition, you get shoulder pain radiating towards the axilla or scapula. That's because the tumor is irritating the nerves. You can get paresthesias and weakness in the nerves going to the arm on the affected side. And then finally, these tumors can sometimes compress the sympathetic chain that's running up that side of the body. This would give the patient a Horner syndrome where they have meiosis, ptosis, and anhidrosis on the affected side of the face. Let's talk about where lung cancers like to metastasize to. They often metastasize to the adrenals. Now, this is usually asymptomatic. So when patients are diagnosed with lung cancer, they often have a total body scan to look for mets, and they will pick up mets to the adrenal glands. This usually doesn't cause any symptoms. Brain mets are also common. This can cause headache and neurodeficits and seizures. Patients with lung cancer get bone mets, and this results in pathologic fractures. And then they can get mets to the liver, and this can give them hepatomegaly and even jaundice and liver failure. The last thing I'll mention is metastasis to the lung from tumors that arise in other places. This is the most common reason for lung tumors. This is more common than primary lung tumors, and this is usually from breast or colon cancer. They commonly go to the lungs. And one way you know it's not a primary lung tumor is that they're usually multiple lesions. So if a colon cancer metastasizes to the lung, the patients will have nodules on both sides of the body, usually several of them. This is a hint that this is likely a secondary lung metastasis, not a primary tumor. And that concludes our module on lung cancer.